First up is Dr. Valentin Fuster. Dr. Fuster really needs no introduction. He is the physician-in-chief at Mount Sinai Hospital and chair of Mount Sinai Heart. Also, Dr. Fuster, on behalf of MSCIC, I'd like to wish you for congratulations for your recent Prince Mahidol Award in clinical research, which has been given to highlight your truly world-changing accomplishments in clinical research. Thank you, and over to you, Dr. Fuster.
Thank you very much. Okay, thank you very much for giving me this opportunity. Yeah, we talk about in a very pragmatic way. Basically, this is a disease that in mid-March, I had two patients with actually clots in the legs. They had venous thrombosis, and they were COVID positive. And at that time, there was some data evolving from China suggesting that perhaps blood clotting had something to do with this disease. Now, at the moment that this came to our minds, we decided to take this seriously, and I will explain to you for a moment. You are very well aware of these 4 different stages of the disease, and I have to discuss antithrombotic therapy in the appropriate context. Here is the asymptomatic individual in which actually the virus gets into the lung, but it doesn't enter into the circulation. These are asymptomatic people. These are people who begin to have fever, fatigue, taste, decrease in the taste in terms of food and so forth. And this is when the virus enters into the blood, but doesn't get into actually the organs. And here we have the patient who already has to be hospitalized. Why? Because here is the interaction between the virus and the defense mechanism, very much led by macrophages. This is important because I believe, and there is good data indicating that when macrophages are activated, they activate the clotting system. And here is the final stage, the very sick patient, in which in fact the small blood vessels in different organs are actually destroyed. And here the clotting system is enhanced by the release of tissue factor. So antithrombotic therapy doesn't have a role in actually counteracting the virus, but has a role on the consequences of the virus, which are actually 2. One is the inflammation in itself, in which corticosteroid treatment has been suggested, and the other is clotting. These are the 2 mechanisms that I think are important as killers of this particular entity. So here we are, these are the patients we actually saw is a scheme. The 2 patients had a clot in the legs, and we decided after some information that in fact different organs could have blood clotting in COVID positive patients, we decided that all patients admitted at Mount Sinai with COVID positive should be treated with anticoagulants. It was a decision made more intuitive than rather scientific. And then we began, about a few weeks later, we began to look at the data. And the original data that we had was about 2,000 patients. And we saw that at least in this observation, those who were taking anticoagulants have a lower mortality and a lower actually admission to the intensive care units for mechanical therapy. So this led about few months later, and this was in about May, that we looked at that more seriously, about 5,000 patients, COVID positive, those who were not treated with anticoagulants versus those treated with 6 types of anticoagulants. And basically we saw a significant difference in terms of mortality. This is what we wanted before getting into a clinical trial. And before I talk about the clinical trial that we just started, let me go back a little bit towards the data. Here we have the patients not treated with anticoagulants, and this is actually the overall mortality. And these are patients treated with at least 3 types of anticoagulants, which I will mention. And here is the incidence of intubation, that is the patients that were the sickest. And this in the top is mortality, and here is the need for intubation. No anticoagulation in the green line, and anticoagulation here in the bottom. Now, what anticoagulants we are talking about? Actually, of the 6 different types of anticoagulants, there are 3 that appear to have the most benefit. One or two were low molecular weight heparin, which we injected subcutaneously at a therapeutic dose or prophylactic dose. And this was actually the mortality. And this is actually NOAC, is a new oral anticoagulant. In this case was a Pixavat, and it actually counteracts factor 10A, and which found that actually maybe it was a trend even in better than low molecular weight heparin. Quite of a surprise, because when we talk about anticoagulation in a very acute illness today, we don't talk about oral agents. We talk about agents that are injected subcutaneously or intravenously. And here's the same data in terms of need for intubation. This oral agent actually did a little bit better than the other agent, but we cannot call this statistically significant. Well, with all of this in mind, we decided actually that we already had this in mind from the very beginning, is to do a clinical trial that would actually validate or would not validate the observations that I just presented. And this is a trial that we began, and at this point I have to give, thanks to Emilia Vagela, and then the Anne Lala and Michael Farku, and actually Girish, all contributing to the origins of the trial, and very much with support of from the Dean, Dennis Charney, who actually says, you should go ahead and I will give you also a hand. So we designed the trial with the people I mentioned and others. And this is a trial of patients hospitalized with COVID-19, prophylactic dose of enoxaparin, therapeutic dose of enoxaparin, and therapeutic apixaban. And you will say, what is the placebo, the control? No control, no placebo. We thought was unethical. This is a very personal feeling, by the way. After the observations we made that anticoagulants could be very meaningful, it's very hard to develop a trial with such acute disease that kills people in saying we have a group control or a group placebo. Well, we developed the trial, and this is a primary effectiveness endpoint. The most important one is all-cause mortality and intubation requiring mechanical ventilation, and the primary safety endpoint in hospital rate of bleeding.